everyone, and welcome to the August 1st edition of Beyond the Data. Although I'm honestly, after the last week, I think we're actually in February and it's Groundhog Day because I seem to have lived this last week last year, last summer. Did we do this all before?
Feels like it, yeah.
I swear it's different people saying the same thing, the exact same stuff. But before we get to that, which is, of course, in reference to everybody has to mask again, everybody panic, everything's going to go nuts. I wanted to start with, well, actually, I think Carrie also wanted to start with something kind of very interesting. Going along with what we had talked about last week about the Delta variant and how we're testing for it and what the rules were for testing for it. So if you want to go briefly over what the rules were or still are as of today, but will change tomorrow.
It will change tomorrow. Yep.
What the rules currently are for genomic sequencing in order to tell what variant we're dealing with.
So currently what happens is each state, based on population, has a set amount of minimum specimens that they have to send each week to the CDC. So you get it taken at the facility, you're tested, your PCR. Ideally, the best specimen is the one that tested positive for PCR. And then that goes to the state ODH, the health department lab. And then from there, 17 specimens are supposed to be sent to the CDC stat lab in Atlanta once a week. Now, you can, if you choose, the state health departments, if they have the expensive equipment and things, they can go ahead and run a minimal amount of specimens, but they still have to be verified at the CDC. So it's not a true Delta if it's not sent there. And right now, Ohio just doesn't have that capacity at the state level.
So all of our genomic sequencing has to be sent on to the CDC.
Yeah, I mean, by federal rules, it has to be sent. 17 specimens is minimum. And then what happens this week, if you don't have 17, then you make up that difference. Next week, it's always a good idea to send more than 17 because if a specimen leaks during transport, if it's not transported correctly, if the form is not filled out correctly to go with that specimen because you're de-identifying. So there's no patient information on these. These are for surveillance. They're not for diagnostic. So currently, right now, no one is being diagnosed with Delta. This is specifically to monitor and see what's happening so we can put data in and, the trajectory analysis and different departments do different things, especially within spheres.
Sorry, to kind of like encompass this, what we're talking about is the difference between the CDC is looking broadly over the country in different regions of the country to see which strains, or not strains, but which variants are growing or reducing in different areas. It is not meant to be used to diagnose an individual specifically that variant. So, but yeah, I mean, this is something that keeps getting pushed around as well, as where people are like, oh, I got the Delta variant. Well, maybe, but there's no way that the doctor can tell you, oh, you've got the Delta.
No. And right now those are running, they're about 2 to 4 weeks to get the results back or get them entered in, because again, this is weekly. So they want, like Ohio needs to send 17 good quality specimens to minimum
good
to
quality.
The CDC. Yeah. Within the last 7 days. So we don't want one that's been sitting there for 3 months. Like the CDC is like, what am I supposed to do with that? There's no material on it to test. And then once it gets to the stat lab in Atlanta, then that's a process. It's not something that's done right now. It's not it takes a long time. So right now the turnaround time is about 2 to 4 weeks. And you have to realize that specimens are coming in weekly from every single state. Those are staggered. But you don't want to, what the treatment doesn't change. There's no treatment difference, regardless if it's Delta, if it's Delta 2.0, Delta Dawn, or if it's Gamma, it doesn't matter. The treatment is the same. So as far as an individual, it's not going to do anything. There's not going to be a significance for that.
And so we don't bother with it is the other
No, that's not the urgency. That's not the point. And that this is all, nothing I'm saying is not public information. I might get it a day or so or whatever before, but everything is public. Anytime you have a public health crisis, that data is public. It's a public health. It's for your health and safety.
One would think, except for I have such a hard time finding the information off of OEH and how they essentially erase the deaths data and stuff.
Yeah, so it's I don't know what they do at the state. Like I can't even. It's awful.
So getting back to the story of the genomic sequencing, we need to have we need to have a person who is symptomatic. They need to have a PCR test. The media needs to be the correct media. It needs to be labeled properly, shipped properly.
Right.
It's got to be a good quality specimen. In the state of Ohio, we needed, to send 17, and also we needed to have minimum of 17.
I can't stress that minimum
of 17. Yeah, we gotta overachieve. Right. Achieving.
It would be nice. Like 25 would be fantastic.
And again, I mean, this entire week, since the very beginning of this week here, almost the very beginning of this week, we've been told we've had over 1,000 cases a day. How in the world are we not able to get 17 specimens per week to the CDC?
So I think there's, because I've been asking, I see a lot in the media. Before I answer that, though, I do want to see, or I do want to answer one question. The question was, are they coming back and telling the patient if they're positive? There's no way to do that because that patient is de-identified by the time it gets to CDC. So there's no way to call up, hi, Mrs. Smith, how are you doing? Just wanted to let you know, glad you recovered. It was definitely Delta. Now, genome sequencing does tell us for sure, no doubt, unequivocally, what that patient has, what has made them ill. But they're barely keeping their head above water as it is. And again, you don't want to identify that patient.
Yes.
You want it widespread.
Yeah, you don't want it's medical privacy,
right?
And that's fine and good.
Right. So, but getting back to, I already forgot. So there's that.
So it is 9:45 on a Sunday evening, and it's been a very long week for you guys too. So, getting back to the quality of the specimen. One of the things besides symptomatic PCR, transported correctly, labeled correctly, not leaking, not old, has to be
not bloody. If somebody, bloody. Yeah, that seems to be a big issue in Ohio. Y'all got some bloody noses, whoever's getting tested, because there's several blood tinged swabs. So I don't know if they're being done incorrectly. I don't know if just the inflammation is that big. So it's extremely sensitive, or are they being tested multiple times? I have no idea. I don't know what's happening. I'm not even going to try and speculate, but for any of you lab people that are out there, or any nurses, whoever is collecting them, if they bloody, don't send them.
Okay. But the other thing, yeah, that's a whole other story right there. But the other thing involved is that, it needs to have CT values of if it's of a nasal, and it needs to be between 18 or 20 at least, or at the highest number.
It was, yeah.
Well,
oh yeah, sorry.
Yeah, you're spoiling the story here. but it used to be the nasal ones has to be below 20, 18, 20, somewhere in that range, the cycle threshold, so that there is enough sample in there.
Right.
And
we call it deep nasal pharyngeal.
I'll let you say it all. Or if it's the oral one, then it can be up to 28 cycles, because you've got your spit, things will break it down. It's watered, it's quite literally watered down. And so or you can accept a higher cycle threshold as being a legitimate infection kind of situation. But you showed me this lovely letter that you got. Let's see if I pop it up here. That you got last week.
Yes, and it is public now, so everybody can find it.
So
I don't know if you can, enlarge that for people to see. Oh, that's perfect. So basically what that is saying is, hey, thank you for participating in the National SARS-CoV-2 strain surveillance. It's not a voluntary thing. Every state has to do it, but you're welcome. And it goes on to say, I don't know if you can scroll down more because there's really nothing. It's just blah, blah, stuff like you hear on the TV, Charlie Brown's teacher talking. Yeah.
Well, here's the good one.
Yes. So, anyways, it basically says, send us your stuff. Yes. And this is still the same. So we're going to randomly selected specimens. Slow down. I'm left-handed, so my brain goes differently. Can you scroll back up? So randomly selective positive specimens Monday for overnight delivery Tuesday. So that means whenever the facility sends them to the state has to send them out to the CDC to arrive on Tuesday, unless it's a holiday. Then you just ship the next business day because it's a pandemic and, we still take holidays, so it's fine. And then it goes on for the Appendix 2 is really important for those lab people that are sending the specimens, but it's also important for the public to read too, I feel, because it really explains it well. There's a form that we fill out, or that is to be filled out, and it's called the global form. And then that form, depending on what code that you put underneath, that's the reason for testing. And we have different categories of why that we're testing. It could be the random surveillance, vaccine breakthrough. There's like 4 really good things that are on there. And of course, our criteria to meet those varies just a bit starting tomorrow, where it's been very blanketed this whole time. And typically these are things in a laboratory setting, like you have to go through and have like an in-service on it, or at least read it and sign off and say, hey, I understand how to do this process. But now we are accepting the upper and lower respiratory specimens, which is the nasopharyngeal, oropharyngeal, nasal mid-turbinate, anterior nares, as well as a wash.
Here.
Yeah, we're accepting pretty much anything you can send us or send them.
Wait, so as of right now, the only thing that were accepted were the NP or the OP.
Right, yeah, which is your nasopharyngeal or the oral,
But now we're going to do the nasal mid-turbinate and anterior nares.
Yeah, or what we used to call a nasal wash or nasal lavage. They're going to accept those now as well.
Are we doing like spit ones yet? Or okay.
Yeah, I mean, we can even take the natural sputum. So what that is like when they cough and it's a real deep lung one, if they can bring that up, then, or if they've had a bronchoscopy, as long as it's in the specific, the buffer and the molecular transport medium, those are excluded. They have to, and we must have like stock in that or something, because there's a lot of specimens, so they're discarded. You can't use them with that, because when you stain them, it turns different colors, and then it just covers up anything that they're looking for. So it really has to be packaged correctly. And again, like I said, anybody can go on there and look and see. I really recommend it because you can really see what they're looking at. It's aphl.org, and then you
Can you
just
put the link into the
okay,
comments afterwards or
sure,
something of that nature, so that because
yep.
I can't even. I have the memory of a goldfish.
Because everything is on there on that website in chronological order. You can see what it was, and then you can see what it's moving to starting tomorrow. So we don't have any competencies. We didn't even have to. Nobody had to get online and make sure that they understood how to do it.
None of the lab techs or anything like that had to be told. That it's
It
just simply, oh, here you're gonna do it now. New.
check your email. But now we're going to everything is a PCR CT value of less than 28.
Yeah. So what
Every
was
specimen.
today? Okay, what was today required to be a very low CT value, which means very high viral load. These people are, if you're at
Truly
that level,
sick.
you're sick, and you are sick with COVID. That's a
Right. I
you
mean,
have
there's
those numbers.
no.
You're real. There's no question in anybody's mind that you are sick. You are sick with COVID. Now we've moved up to 28, even for the NP samples, and at 30 cycles, that's where already the hard cutoff is that
Right.
you don't have any infectious people over 30 cycles, and they can't. They've tried for a long time to get
Yeah.
some samples to
No, the only thing that you can see with a 30, if you had an immunocompromised person that was taking like a DMARD or something, they're just, but that's with anything. They're going to hold out that illness longer. So they're going to shed it a little bit longer, and it's going to have some live stuff in it. But if you are a typically functioning within normal limit system, then even if they're shedding it at that high, chances are, I'm sure there is a fluke there, but it's so low that it's not even something that's studied.
yeah. So now we're accepting things that are basically right up to that level.
Just give us everything you got. That's
Everything you
basically what
got,
they've said.
whether the person, and basically even we're talking. I'm wondering, are they even caring if you're symptomatic or not anymore, or you just
That's one of the things that should always be.
yeah should
So that, I mean, that is in here, and that did not change. As there needs to be some symptoms there, because otherwise there's too much. You have to take all the unknowns you can and wipe them out. Of course, you're never going to wipe out every single one, but as many as you can. And then it goes on to just explain what it is. And there are some states that are doing really good at sending, so those states are moving to a bi-weekly.
ooh.
Yeah.
Wait, so
Ohio is
they
not
need
one
to
of those.
go. They only have to do biweekly, and we have to do it the second we have one
Right.
officially.
It would be nice. It would be nice, but the state still has to send them. So
Was there
that
anything on this last page here?
I don't know. I think I maybe just who it was signed by. I can't read it. It's super duper small, so I can't read it. Um, so and again, so Appendix 1, 2, and 3 is up there. Highly recommend. Highly recommend everybody going and looking because it is very step by step. It's like how to make a peanut butter and jelly sandwich step by step. Somebody asked how did they come up with the number 17? Because it's just so out there. It's based on population. So if you look at that Appendix 3, there's not a state that has a huge number. There are states that have a larger number than us, but 17 is kind of right there in the middle. But that's how it's done. I don't know the formula that they use. I just know it's based on population and the number 17. The other thing somebody had said, so how do they know if you even have SARS-CoV-2? How do again, SARS-CoV-2 is the virus. COVID-19 is the disease caused by that virus. So COVID-19 does have the ability to show up on a PCR test.
Well, SARS-CoV-2 has the virus does, not COVID-19.
Yes. Sorry. But look at what it says on the actual test that you're taking, because there are a couple that do say COVID-19 versus SARS-CoV-2. Want to make that clear. Yeah. And so those would be the ones. I don't want to call them bad. I'm not saying that, but you're going to get what you test for. So keep that in mind. You're going to get what you test for.
And again, just because you have a pathogen of any variety in or on your body does not mean that you are infected with that pathogen, nor does it mean you are infectious. We all have strep.
Right. And, we have to make sure that we're following the EUA specific for that test. So yes, there were 2 different ones that this past couple weeks, either they're being discontinued because it's shelf or sell time, or the other one was for that one is being taken off because they're coming out with a simplex test, it's called. So you have CLIA and simplex. So keep that in mind. And then your antigen test versus your PCR test. So always know what's being used to be tested with, because that's going to tell you, how accurate that it has the potential to be. And the test will tell you, just if you know that name of it, and keep in mind, UH has their own, Cleveland Clinic has their own, and those all have an EUA. But theirs is very easy to find. It's right on the bottom of your test result, and most of us have access to MyChart and things. So that's really easy to be able to locate. So just because one is being taken away, that doesn't mean that it was bad. It could have been. But you have to look at the reason why it was taken. I promise if they're saying, hey, we're going to stop July 15th, we're going to let you know we're stopping in December. I think a lot of people read that as all the PCR tests. No, it's not a blanket thing. It's each individual one.
Is individually determined as well. And that's a sticking point. Yeah.
Right.
PCR test detects the genome, and that's it. That's all it's doing. And each individual tests for different parts as well.
Correct. Yep. And if you look at, and a lot of people have taken that comment out of context without the full thing, is the CDC, and I saw like 4 headlines today and my eyes just crossed. The CDC said that the PCR test was unreliable. And I'm like, you forgot the rest of that sentence. The PCR test is unreliable to detect the Delta variant. Yes. Or Gamma or anything else. We're not going to get that variant on a PCR test. It will not happen. That's not how that works. And there was a PCR test that was extremely unreliable. And the object of that test, it was a combo test, was to detect flu, and it was one maker, one brand, flu and SARS-CoV-2. And it failed.
Except for now, they're encouraging more combo tests, which is
you do want
to be able to do that, but at the same time, if you're already failing, I do not have particular confidence in their ability to not screw things up.
I'm not saying I do either. You got to remember, every test that's CDC. Ooh, I almost said something wrong. And it's FDA approved, has to operate within a 2 standard deviation. When it's an EUA, they do not have to operate. Of course, that's the goal, because the goal is to be approved. But they do not have to operate within that 2 standard deviation.
They get to go outside of it. Now, I mean, early on last year, about this time, I got my hands on some of the performance testing from who was it? Can't remember who it was now, but it was an association that went and did testing, blinded testing on all of the labs that were running the different manufacturers' tests at the time, the ones that existed, the PCR tests at the time. And the results were, you've got all of these different labs running it,
Mm-hmm.
the same manufacturers, and then they just simply sent out positive tests, known positive tests and known negative tests, and they just put it through their cycle. And there were ones in there where there was one test that I do know was being used and probably still is being used in the state of Ohio, that had I think it was about a 14% false positive rate. And it's a PCR test, but most of the other ones were, 99% accurate when in terms of being able to accurately get the positives. So only 1% false positives. But we have mixed in there other ones that have, 15% of their positives are actually false positives. So
sure, but that's with any test.
That's with any test, but the trick is if we do not know which brands are being used in which places, and we are not, as consumers, essentially being given that information, that's critically important. When you're looking across counties or in the state of Ohio or even across the country, depending on which tests you're using, it can either be, that's a really accurate test and you should trust those numbers that we are truly detecting these things at this rate, or not so much. These
right. And I looked at, I was at Rite Aid and I actually had to walk in, which I haven't done that in a long time. But I had to actually walk in and go to the pharmacy, and I was shocked because at the beginning of the year, they would hand you a free at-home test. And then about around Easter, we laughed because we're like, well, look at there, it's a penny. They're charging a penny. That was the price on this. And then if you brought it back, so it could be entered into their electronic system, then it was free. They gave you your penny back, whatever. And so, right. So if I'm positive, I'm going to go back out again to get a penny back. Probably not. However, and then they would give you the printout and, you got your penny back, whatever. But now one of the tests is $24.99. The other test is $99.99.
Wait, one-time use?
One-time use.
So it actually has, it kind of comes along with this comment that popped up. Was it showing?
Yeah, I see it.
Okay. On mine, it's not showing. But
you don't need to see it. You're the person. You're the main person.
I don't get
for
to
us,
see
not
it.
you.
But so yeah, I mean, this is something rather important now. We're entering, and this has happened in Europe already. So this is not a crazy conspiracy theory. This is the clear path that we are on right now. Is that you must be vaccinated, or if you are not current on your vaccinations, then you must take a test. And if you take a test, that's on you. You have to pay for it.
And that's actually happening at colleges.
Yeah. Oh, geez. Are you kidding me?
Yep. The student athletes at a college here in Ohio, it's right in their contract that they sign. I won't do drugs. I won't do this. I won't do that. And if they are not vaccinated at that particular college, then they have to take a test, but the test is at their cost.
Which
so if
college?
Bluffton.
I don't know Bluffton.
It's a Mennonite college. Right, which was shocking. But that just came out. So yeah.
But I mean, this is clearly the path that they're working on. Is that you can get your vaccination for free, and everything is smooth and easy. Or we're going to, since we cannot mandate it on you, we're just going to make your life impossible, expensive. They cannot officially tax us if we refuse to take the vaccine, but they can
never refuse. Never ever refuse.
Yeah, don't refuse, but just decline to.
I wouldn't even. I would just, I would start asking questions and make it very uncomfortable for them, where they're just like, oh, I don't even want to deal with her anymore. Just give her whatever she wants and get the heck out of here. But
Carrie's getting, you got to do like, some training sessions for us all.
I'm pretty good at it lately.
You've really gotten some skills. In the recent past, you've definitely developed some skills of You people have displeased me. Um, but kind of actually going on very much into that vein of just like what they're doing in terms of trying to convince the hesitants to get this. It's so funny. I mean, it's just like,
And coming down, think about it. This is the time to push.
mm-hmm.
If I was somebody that needed this for profit, this is the time that I would push, because one, the liability becomes once it's approved, not by the manufacturer, but by whoever is mandating it.
Yep.
That's number one. And number two is, while that, when the United States and then each state signed a contract to take a bulk of whatever brand of that vaccination, if they're not meeting that, then at a certain date, whatever that date is, and I don't know, if they haven't met that, then they start having to pay for any extra that they have. And you'd have to look at CMS, which is also public, to see exactly what the cost is per vaccination, because it has changed recently. So I don't know, and I don't want to quote and be wrong, but so that's going to be quite, somebody is going to, we would have to pay
Yes, pay it.
yeah, we would have to pay that to the federal government, and the federal, the state of Ohio would, and then them pay it to the manufacturer, because you didn't get the product in, and they're relying on that for, their long-term study to 2023 or 2022, depending on which one it is. So, if it was me, absolutely, this is the time that I would be pushing it. Let's get as many free as we can when there's no recourse, but we can still monitor that progress.
And also, yeah, it is this baseline of trying to take advantage of normal seasonality that is occurring, that we're claiming it's all because of how awesome and wonderful we are. So anything else you want to say about the Delta variant stuff before we,
other than,
about the testing, because we're going to talk about
yeah,
breakthrough and the
yeah, just, for years we've said people need to take individual accountability and responsibility to be their advocate. They need to take control of their health and their health care. And this is the perfect time. And I think it's a struggle. There's people saying, hey, I want to decide. And the government that has constantly said, and healthcare providers, you need to be accountable, to be compliant, and to do what's best for you. I give you the tools, but it's ultimately your responsibility. Now they're trying to say, no, you have to listen to me just because, so it's very disorganized, and it's confusing to a lot of people. I see that confusion a lot. And I think we're focusing a little too much on COVID.
Oh, beyond COVID. Yeah.
Yeah. Like we have to, there's things in society that are bigger than COVID, or as big as COVID, that deserve that, of course, I'm probably not the most unbiased person, but that deserve that, our kids deserve that. Our elderly deserve it. I was just told that our nursing homes are starting to go back on lockdown, and that is just.
Yeah. Well, so we'll get to that too as well. Okay, why that's happening, because and they will do it. This is a guaranteed that this is going to happen. That they're going to shut down our nursing homes again this winter. That's a given. Get your loved ones out of there, quite frankly, because this is not ending, and they actually have some reason to do it. So the first thing I wanted to talk about with this whole business of the CDC talking about the new guidance in terms of vaccinated now need to wear masks again. Yay! Well, here we are, this whole situation that they've argued now for almost a year and a half is we need to just do these non-pharmaceutical inventions like masks and distancing and quarantining and all those things just until we reach a vaccine-induced herd immunity. Because they've never acknowledged natural immunity.
No, they didn't. But what is a year ago, what was the level, the percentage to reach to be herd immunity? It was 60.
You read my mind. I love it.
Oh, really?
So,
Okay.
that's exactly the thought I had as well, because I remember in January, and that's when this article is from. There were news articles coming out telling people, now that the vaccine is out, don't expect things to get better really fast, because we won't see the impact of the vaccinations until we have significant amounts of coverage.
Oh, we're
And
seeing the impact.
well, it's a different kind of impact than the one they were talking about. But this one right here was talking about, how many do we need to have vaccinated before we would see transmission shots dropping? Because they said this for a long time, where they're like, oh, well, we need X amount before the transmission is reduced, not stopped, until it is forcing its way over that hump.
Yeah, it's not going to stop.
But this is how they're trying to put it in our heads now, that we're going to stop it somehow. But originally, last year or this year, January, they were telling us, by the time we reach about 50% vaccinated, that's when we're going to see the peak of our curve. Yeah, we've seen the peak of our curve. We went blowing right on past the peak of our curve before the vaccinations even started. But this one's talking, it requires more than 50% of the population. We haven't even hit 50% of the population now in August in the state of Ohio. And we have gone over that hill and down the other one and up the next. I mean, this is...
Well, and if they keep talking about it, keep pushing it, they're really never going to, because that, I guess I look at those... especially the Amish, living in this area and, being very candid with many of them, that's the last thing. It's just not going to happen. Keep talking about it, and it's just not going to happen.
So here's another thing where it's like, when we're talking about transmission, here we have Holmes County. It's our lowest county of vaccination here. Not even 15% of Holmes County, which is, of course, the highest concentration of Amish in one county in the state of Ohio. They have refused it. I mean, this is just no. This is not hesitancy. This is refusal. And interestingly enough, this particular colored map is the map of fear from the CDC. And interestingly enough, our lowest county was the only county that was low transmission.
Yeah, and they're not playing with your test either. Do not try and come and do a surveillance there. They already ran them. They said goodbye.
It's kind of funny. I mean, why would you think such a thing? I mean, obviously the vaccination is the only thing that's controlling the trans... how does... doesn't work. It does not work. I mean, our best county is the least vaccinated. So already right there, the idea is that their postulate is wrong. Something else is going on. You can argue that vaccination might have a part, but it's not. It is not.
Oh, actually, by this, and somebody said it. I don't know. I lost the comment already. That absolutely. That whatever county they live in is red, but they have the highest vaccination rate. Well,
it's probably Warren. Or close to be.
Something's wrong when you see the vaccination rate go up and your infection rate go up. That's not normal. Gee, what did you expect to happen when you vaccinate during a pandemic? You don't do that.
That's not what you do, because you're going to encourage, especially, not only that I think that's another thing to really, hit home a little harder today as well, is that it's not only about just vaccinating during an epidemic, which is a bad idea because it encourages novel forms of the virus to evolve, because you're putting on these extra pressures. In this particular instance, we are dealing with just a few vaccines that are only targeting very small sections of one protein in that virus. So even if you're talking about, if we were having a measles epidemic again somehow, or whatever, those things involve a virus. They involve the whole thing. it's so your body will recognize different parts of that virus. They'll recognize different parts of different proteins, and so therefore has a better picture of, you know, what it's actually able to recognize. But in this particular instance, with these particular vaccines, we've limited it to just tiny little chunks of just one protein. And so all that needs to happen is just one little change, or just sufficient change in those tiny little chunks of that one protein, and suddenly the vaccine is useless. And it's useless for everybody. While if you're dealing with something more like a more classic vaccine, a smallpox vaccine, a polio vaccine, measles, any of those, different bodies will recognize different parts of that virus. Mm-hmm. They just will. And so you don't have the evolutionary pressure that we have created in this instance, and then have given it to hundreds of millions of people.
Did you get a smallpox? You're young.
No, I did not get a smallpox.
I wasn't sure if you got, you know, the lovely mark from.
No, I do not have the lovely mark. I am definitely far, far too young for smallpox. I even had real chicken pox. I'm that old.
Oh, I had real chicken pox too, like for real. But, you know, I also had a large family, and they're like, good. My mom kind of said, good, you know, we'll get it over with.
But your body recognizes the whole virus, every part of it, even if there is, you know, some mutation in chicken pox. Mm-hmm. Even if one part mutates, your immune system will recognize another part. And that's exactly what we have seen. I unfortunately, I don't have the papers at my fingertips right now, but there are several papers that have actually gone in and looked at people who developed natural immunity to SARS-CoV-2 versus those who develop the vaccine immunity, because the vaccine immunity is, of course, only to the subsections of the spike protein.
Yeah, and I think, you know, we forget that lineage and what we were talking about earlier.
But the naturally acquired immunity, they actually have immunity more towards the other proteins, not so much the spike protein, but the N protein, and I forget what the other protein is, but other proteins within the virus that naturally acquired immunity knows. So even if that spike protein changes, people who have natural immunity, which it has,
that's why
we're having our problems. Natural immunity will still recognize that virus because it still recognizes a different section of a different protein, and that's critical. So now here we are. We've given these vaccines to hundreds of millions of people throughout the world, all the same stuff pretty much, except for a couple countries that do it slightly different. But Pfizer is everywhere. We have the problem of our potency is going severely down. So this is an article I found, I think it was like in Times of Israel, I believe, which is really interesting. This just came out just last week about the mixed results about Pfizer's efficacy against the Delta variant. I like how they call it the Delta strain now. We're just going to throw words out at this point. We're not even going to.
That I blame. I truly do. I blame the report. I tell you, journalists and reporters and me are not, you know, because I just think that adds to it. And either do the legwork, investigate it, make sure it's accurate, print a retraction. If you mess up, that's fine, or be quiet, because, you know, and I'm sure for you too, and your husband, and probably your mom, from a scientific perspective, you're sitting there going, oh, they did not just print that, you know. Your eye twitches because it's your last nerve and they're on it because you've seen it so much.
No, you've seen what I do in the situation. I take screenshots and I underline things.
Yeah, you're like all organized, and I'm like, oh my gosh, this is ridiculous.
But so here we are. We're seeing real world data from the UK and Israel, and both the UK and the Israel. The data that I've seen coming out of them, at least, seems to be quite good. I mean, they make a very good conscious effort to make their data as clean as possible. Now, there are, especially in Israel, there was a series of papers that was quite. I need to put that together and translate it in the way of the way they're hiding deaths with after the first vaccine, and it's pretty ugly that way. But they collect the data well. The UK collects the data well. They separate people who have been vaccinated, people who have had one vaccine.
Well, not now.
What? They stopped it?
Yeah, as of tomorrow. There was like a bulletin that came out that they will no longer be separating the vaccinated and unvaccinated. And I was like, of course they're not.
UK is?
Israel is not going to separate vaccinated versus unvaccinated in their data. Now, they might know, but it might not be public. Before you go on, and I know I interrupted you, I'm sorry. I want to make sure that do not let us forget to go back to Tracy and Nicole's comments, because they're really good. And
where are they?
I see them. It says 1023.
1023.
Yeah, and even if we don't get to it tonight, but Nicole's definitely, there's actually studies that have come out and they're published in the NIH, and that actually makes sense, to be honest. She said last week in Israel, 80% of deaths over age 60. Oh, we are getting there? Oh, never mind. Sorry, Nicole.
We're all in this, synergistic mind.
Sorry.
We're all thinking the exact same thing. I love it. It's great. So here, this is talking about the Israeli UK data. The Israeli data, this is just coming out, and I'm so disturbed that they are not going to be separating vaccinated from unvaccinated, especially after this. Because they themselves, their data is saying that Pfizer, which is the vast majority of Israelis receive Pfizer, they're showing it's only 39% effective against infection and 41% effective in preventing symptomatic COVID.
But that would make sense. It was not designed to prevent infection, ever.
Nope, it never was.
Yeah.
But that's the thing where their own data is showing us that the effectiveness has dropped by more than half. But the UK is being a lot more, shady with their data. They're saying, all is well, it's all so good, and all that kind of stuff. And that really should make everyone kind of.
Well, we are too, Well,
we're saying it's all good too, because we do not test everyone. We're only testing hospitalized or dead.
Yeah, they have to be hospitalized or critically ill. I believe they're still doing postmortem. I can't say one way or the other, but I think so. But it'll never, that's a whole nother thing. But that Israeli data has always been really, really good data.
Not anymore, I guess, if they're not going to separate vaccinated from unvaccinated. So here, exactly, getting back to, I think it was Nicole's comment there about the ages and stuff like that as well. So, I mean, this isn't exactly there, but what they found is that people who were vaccinated earlier, so before February, were twice as likely to get infected than those who were vaccinated later, say like in April.
But we knew that too. The manufacturer, as much as I'm like, they have hid nothing. It's there. It's published. It's, our leadership and our media, they're the ones that have said and quoted 100% effective and ugly things that should not, to me, that should be flagged for misinformation. I mean, if we're being fair across the board, Kathryn gets flagged for using the Ohio data.
I get shut down.
And
thrown in jail.
Like those, that should, because it's not true. It's never been published anywhere like that. And they knew, because that's how long that the first leg or first arm, it was the first arm of that trial went, was 6 months, but we don't know. They didn't say it wasn't, just we don't know beyond then. Well, now in a real world setting, we're seeing
Yep.
we're starting to see we do know.
Well, and the fun part is even in this, I mean, it's the constant twisting and manipulating, and they try to say we don't know, we don't know, we know. No, yeah, but we do. We can look at what, just in this tiny little article, I can tell you a lot about what's going on here. And it's so simple, because it's saying, okay, people who were vaccinated before February, who tended to be the older, more susceptible, more frail, the ones we wanted to protect, the over 60-year-old crowd, for instance, the one who are now dying while vaccinated, they are having the vaccine wear off. And what's funny is, even in this article, they're like, well, maybe it's because of the Delta variant. Well, wait a minute. If you see a difference between people who were vaccinated with the exact same vaccine from February to April, then it's probably less about the variant and more about the durability of your vaccination. I mean,
Wait, and we have a published study at the NIH that says, because of the underlying condition, I think I had posted that a few weeks ago, this might not be the best one for those with neurodegeneration, so our elderly, because their system is different the older that they get.
And it does. Yep. And it doesn't maintain. I mean, the bottom line here, there, 16% protection against infection now. And in Israel, they are talking about doing a third dose to the elderly now.
And that was mentioned at the congressional hearings.
Yep. Do it again.
Last time. And the thing is when you have that ceiling and you have that response, that's it. That's all you're going to hit. You can only hit as much as you can. Actually, the congressman, which is also a physician, was saying, why are you even giving a second shot if they've had COVID before? If we have all these other countries begging for vaccines and we have all of these in stockpile, that are about to expire, which we did extend that again. Why are we giving a second one if the whole point of the mRNA vaccine is to achieve the body to recognize and achieve a response as if it was infected, and recognize that? Then if you've had the infection and you get a shot, why are we doing a second one?
Because we can, I guess. I don't know. I think, honestly, as diabolical as it is, that it's this mentality of we have to convince people that their natural immunity does not exist, because I don't know.
It does, and we have information, like the studies from the manufacturers they're giving us that information, like it's there. We need to start talking about it. And Dr. Cassie does not represent Ohio, but he's a senator, and I cheer him on every time, because I'm like, yeah, and he said basically until you can answer a question, Dr. Fauci, against natural, then we're not going to talk about your shot.
Yeah, I like him. All right, so the next thing I'd like to talk about. So we've talked about now that the vaccinations, what the idea behind the vaccinations was, is that, all right, well, it's going to take us a long time to reach a decrease in transmissibility, right? Well, that happened long before we got far. In fact, I put this up on my group page earlier today. This is from Ohio. I've been getting a lot of requests to put this one back up, because we're now dealing with exactly the stupid stuff again, where we're going to put masks back on. We're going to keep doing all this stuff. The mask mandates are coming until enough people are vaccinated. So our arguments are, the only thing we can protect ourselves with are masks and vaccines. Well, okay, let's just use our data, the cleanest data that the state of Ohio has, because Ohio is such a mess. But at least with ICU beds, we're dealing with the least amount of slop. These are absolute numbers. They do not change, or they occasionally change, but not by very much. I mean, by 1 every week maybe something moves, but that's it. But here on this graph, I pointed out where the mask mandate went into effect. Maybe you can argue maybe something happened there because there's going to be a delay. But then we went into that huge upswing in the wintertime because it's seasonal. And they like to say it's the vaccines that did all the work. Well, I pointed out right before that interesting spike, it was a very interesting spike, that the first few doses were first few dozen doses were given in Ohio. So that was December 14th, and the big spike is December 15th. It's interesting. I don't know if it has any meaning, but it's interesting. And then they keep telling us now, oh, you need the 2 doses, and you need to have 2 weeks after the 2 doses, or you're not fully vaccinated. And in fact, if you read all of these articles that have come out saying, oh, everybody in the hospital right now is unvaccinated, it's a pandemic of the unvaccinated and all that. Well, they don't actually say that. They actually say it's unvaccinated or not fully vaccinated, meaning anybody between the first dose and 2 weeks after the second. So that's when they say that the vaccine has the effect. So the very first point that we have on our little graph here, where we have over 1,000 people, just 1,000 people out of over 11.5 million getting a dose, 2 doses, 2 weeks after that, that happened way down the slope. The vaccinations didn't do this. Vaccinations had no effect on the shape of that curve. You don't even see any change there. And then when we get to the lowest point we had after the big seasonal thing, we only had 8.4% of Ohioans fully vaccinated. We're now at close to 50%. And they're still sitting here claiming that the vaccines are all that does it, or the mask mandates. It's clearly not true. It's just not true. But we still need to do all the masking. We still need to do all of the vaccination. And then we need to vaccinate and then mask.
Yeah, I don't know what we're doing. I don't understand.
Well, it's not about a virus. It's about control. Because this was my favorite one from last week there, the CDC director Walensky there, where we're entering Groundhog Day here. I mean, it really is just to the point of...
What does that mean? So are we at February 2nd? I don't understand the Groundhog Day thing.
You've never seen the movie Groundhog Day, where the guy lives same day over and over and over and over and over again?
No, I thought that was 51st dates.
No.
Oh, okay.
We're gonna have to educate Carrie. Okay. Man, she is disconnected from the world.
I was like, why are we going to February 2nd? I don't understand the significance of February 2nd.
You need to live a little, Carrie.
Oh yeah.
We're living Groundhog Day, the movie. Mm-hmm. Okay, so we'll have to work on that in all of our spare time.
This next couple of weeks, yeah, it's going to, because a virus mutates, or it changes on average every 14 days. And if it's going really fast, then it's going to drop really fast. That's what it does, that mutation. That 2 weeks, if it takes you 6 weeks to be vaccinated, 2 weeks doesn't mean nothing.
Well, that's the funny part to me, is it's so funny. They're so transparent on what they're doing, where I think just literally a couple days prior to this tweet of hers, she was saying that everybody needs to get vaccinated now for the fall, because it takes like 5 weeks for it to take full effect. And then within a day or two, she's saying this, oh, well, if in the next couple of weeks we mask up and we get everybody, started vaccinating, suddenly we'll control the shape of the curve here. And I thought it was so funny. I'm looking at the shape of the Ohio curve, and each one of these bumps here represents a week, because in Ohio, our COVID is very respectful of our weekends.
It's smart and cunning, and
it's a sweet little virus. It knows when it's a vacation, it's a holiday. Mm-hmm. weekend, and it doesn't really want to bother us at those times. So
No.
we see each of these weeks so nicely lined up here, right?
It
Nice.
knows all the things.
It knows all the things. So when she said this, and I looked at the shapes of our curves, so the dotted line is from 2020 and the solid line is from 2021, and I put these up on my daily misinformation posts every day, showing how it changes from day to day, so you can watch it in real time with what they have available to us, and you can see the pattern. You can see these weeks 1, 2, 3, 4, 5, 6, and we're echoing that curve, just shifted by about a month. 1, 2, 3, 4 weeks. What happens in 2 weeks if we follow the pattern?
Well, historically,
Not only with this virus, but with other viruses as well, we're going to drop.
right.
They're just sitting here trying to take advantage of a natural seasonal drop.
Yeah, just can't with her. There needs to be a complete overhaul. If it was me, and I don't know who has the power to do that because I'm not a political person. But if it was me, I would shut every one of those places down and clean house, and they can come back up and be up and running whenever they have their head on straight, because this doesn't follow anything, and it's not because it's a novel virus. We've had viruses forever. We've had pandemics.
We've all experienced the exact same situation.
Yeah, and they are bad and they are scary, and there is a fear of the unknown, but this is just ignorant at this point. I don't even know if that's the right word, but that's probably the PG word. This is, this, because I could say a whole bunch of other words that weren't so nice, but there is no reason, no humanitarian reason. There's no financial, well, there's a financial reason for them, not for the citizens.
Us.
Right. And I don't like our governor either, but that's fine.
Oh yeah, and you were spared. I had videos of Governor DeWine loaded up here, but since we've reached the hour point here, and I think I'd like to just end with this one last thing and not get involved in DeWine because he's such a there's plenty to be angry about. This particular slide, though, I did want to point some things out on. This comes from the CDC's not public slide deck that the Washington Post got a hold of last week, before the CDC was forced to admit the data that was coming out when they were starting to say, oh, even the vaccinated need to wear masks, because of course the whole business. Oh yeah, we didn't get to that point. The whole business of what the CDC was saying for their reasons that everybody needs to wear masks is they are saying based on a study in Massachusetts through July, where they found that there were almost 500 cases of COVID-19 associated with a bunch of people partying in one of the most heavily vaccinated counties and towns in the state of Massachusetts. They had
partying with alcohol, because I thought good alcohol killed everything.
Well, apparently they were specifically calling out places like bars and restaurants and parties and all sorts of things like that. And so it just so happens that 74% of the cases that they found that they could trace, contact tracing or genetically tracing them to contact them, were in fully vaccinated people.
So they were 2 weeks past their second dose, or
more than 2 weeks past their second dose, fully vaccinated, couldn't even twist that anyway. Interestingly enough as well, not only did they have 74% of those cases, the coverage among eligible Massachusetts, well, actually, I believe in that region, they had 80% coverage, vaccine coverage overall in that county. So
Did they test positive, or were they through contact tracing?
They tested positive, and the vast majority of them had real symptoms.
Oh, they were symptomatic too.
They were symptomatic. And you didn't read this study, Carrie. Goodness.
Well, I mean,
Well, you've read other studies in the same region, but there's the other fun thing about this particular study as well that they kind of like brush under the rug a little bit is that they had 5 people go to the hospital. Their symptoms were so severe,
Fully
and
vaccinated? No.
one was unvaccinated,
Okay.
and that person they said had multiple underlying conditions. So
Okay.
clearly, this person was already had a lot of things going on, and did I think that person was even in a more dangerous age range as well.
So is that the one they said started it?
No, they haven't
Oh,
claimed
okay.
any starts, but they're actually being relatively honest with this. Quite frankly, they're being very honest for the CDC,
But
which
I
makes me nervous.
but a national to do this to our children, right? Or I don't have school age kids, but to school age children on a national level based on one small peer reviewed, not peer reviewed, I just I'm struggling with that because is this an isolated incident? And then my next question will be, okay, wait a minute. If all of these people are fully vaccinated and that's the level that you want us to be at, and they are that sick, do we what's going on? Do we have, vaccine escape? Do we have vaccine failure? Those are different things. Do we have breakthrough? That's a third different thing. There's a whole lot of information for a little bit of honesty, but to control and to limit the nation based on that one,
I
that's
don't think it's that one
insane.
because as we all well, that's the one that they put out. But obviously,
Mm,
they see the data. They see who's a breakthrough case. They know and they also know in terms of the vaccinations, in terms of the cases that are happening post first vaccine or second dose, but before the 2 weeks post. I mean, all the data that we see coming out of Israel and the UK, they have it too. And I'm sure they're
mm.
seeing the exact same things. And I just think that they are probably just only giving us one little nugget of what they really see all behind
But
this.
my thing is, why?
So that's actually a good point there because I don't know if I have that slide in what I had here. I was thinking about that too. Why? Why would they be doing it? I don't think I do. I think
But I
I
mean, not so much why would they be doing it, but why is this happening?
oh, in terms of vaccine escape or vaccine
Is
failure.
it right? Which one is
I think
it?
I think it's probably a combination of the two. The way we would be able to tell the difference is exactly what the Israelis were doing, which is saying, okay, how long ago did these people have it? They were actually saying that the vast majority of cases were in the 60-year-old crowd, or not 60, sorry, 40-year-old men were the most likely. So that's an interesting one. One thing I wanted to
Hmm.
finish saying about, yeah, exactly. Isn't it interesting? But the one thing I wanted to say finish about the hospitalizations. So there was the one unvaccinated who had multiple underlying conditions, and then there were 4 vaccinated who were hospitalized, and 2 of those had underlying conditions, and the other 2 had none. So these people were fully vaccinated, greater than 2 weeks after their second dose. They got COVID. They got sick. They got so sick with COVID that they ended up in the hospital. And I think 2 of them were in the ICU even.
And do they break down what vaccines they're getting or no? Do they say like,
Yes.
okay, I'm going to have to go back and look at it.
Yeah, they did. They said that
Because I mean, we know Johnson and Johnson has a lower
no,
efficacy rate.
yep, they did say that they did break it down by what each one was at some point in here. I just don't know where it is. Uh,
Okay.
but they did, and it was everybody. Yeah, everybody had they had all 3 varieties of the vaccines in there. Um, and maybe we just kill it there. No, I do want to talk about this one slide and how they manipulate their data and how they say this. So this leaked out to the Washington Post on Thursday, I think it was Wednesday.
So it's not, when it pertains to public health, there's no such thing as a leak. I think that was like an attention grabber for the Washington Post. I'm not sure. But there's no leaks. It's public health, so the public has the right to know.
I
That's
like it.
silly. Yes.
I'm going to ignore the confidential on the bottom of this slide then. But this slide makes me so mad here, because in this slide deck that they had, they were trying to say, oh, this is why we need to all vaccinated need to mask. And of course, we always knew it was going to be this way, that the more people who got vaccinated, the more people who are vaccinated would be in the hospital. Suddenly they discover this particular feature of this kind of stuff, like with testing and stuff. Now they're starting to notice it. But they're saying that the more vaccinated we have, the more we're going to have in our hospitals. The vast majority of people who took the vaccine ending in April. So what we see here with the blue line are the blue line are the people who had taken the vaccine and ended up in the hospital. And the yellow line is those who did not take the vaccine and ended up in the hospital. And we can see actually that after April, the number went way, way up. Now, we should have seen April be roughly equal to May if the vaccine was, just the sheer number of people who are vaccinated is what's controlling the number in the hospital. We should see April and May be about the same. And then comes the question of, this was released in the middle or the end of July.
Mm-hmm.
Where's June? Where's July?
What do you mean?
Where are the numbers?
July just ended, so it wouldn't be on there.
But June, there's no reason why we can't have June.
Yeah, that's because of the way that your fiscal year goes. So
June just didn't happen. We don't because this is a very respectful virus, and we got to respect our fiscal years.
Correct. So there's a lot of things that are not done, and a lot of reorganization that occurs.
Oh, for real? This is for real? That they're just being sloppy?
Yeah, and like things get transferred over, like getting transferred over to spheres and things like that. So, and there's a lot of things that happen. So that, if you look at a lot of studies that's done or data, there's a lot you don't see historically in the month of June.
So maybe my archives is incorrect, but I still would say that April and May should be equal if we're talking about vaccine coverage being the reason why there's an increase in hospitalization month over month, and specifically a high increase in those vaccinated in the hospital. There, I'm done.
And you're probably right too. But if it's not on paper, anybody that's in healthcare knows if it isn't documented, it didn't happen.
Guess what? I live in the real world, not in the healthcare world.
Right.
If it happened, it happened.
I agree, but I'm just playing devil's advocate there, just like with universal precautions. I do that regularly, and people want to throw tomatoes at me and things. Yeah. So before we do go, I do want to, we've all been through a lot this pandemic, every single person, and we've all lost a lot, or things have changed. And I know that there is a huge amount of people in, the ALS that's just near and dear to us, that are watching. So Mrs. Andrews lost both of her boys within a year to ALS during a pandemic. The second one was today, or early this morning. So I think all of us here at Beyond the Data are definitely thinking of their family this evening. And even with all of that, I appreciate them tuning in to watch us for some normalcy.
Thank you, Carrie. You're much better at that than I am.
Have a good night.
Good night, everyone.